I am so honored to be here, and I too would like to thank the organizers and the sponsors for having the vision of pulling this conference together. And it's really, I'm here, and experts are always people who are at least 30 minutes away. But as I look out, I imagine that there are 150 experts in the audience, and that each person has something to share, whether they are a researcher, a clinician, a practitioner. I seem to be echoing. Am I okay? Okay, excellent. So what I'm talking about today are public health models. I work in a school of public health at Texas A&M, and we use these models for both planning and evaluating implementation research. But I really give appreciation to the Riain collaboration group. And you're right, it's Russ Glasgow, but it's more than Russ. There are many people in the U.S., and it sounds like also internationally, who are familiar with and applying Riain. So what am I going to talk about today? I'm going to start off with U.S. public health goals and challenges, and I think the public health goals in the U.S. are probably very similar to the ones in Europe. I'm going to spend some time talking about Riain Framework to give some definitions of each of the dimensions, and then talk about the application and the evolution of Riain, because just like research, frameworks are not static. I'm going to talk about some efforts to promote dissemination and implementation research in the U.S. People may think of dissemination and implementation as problems or challenges, but it's also an area of research. So I'm going to talk about models and frameworks and then end up with some resources. So let me begin. Okay, now I'm not echoing. This is wonderful. The U.S. government has Healthy People 2020 goals, and every 10 years we update these goals and we do mid-course corrections. But I think the goals are so important because it's really to attain not only longer lives, but lives that are free of preventable disease, disability, injury, and premature death. It's also to achieve health equity, so it's health for all. It's to create the social, the physical environments that promote good health for all. So it's the public health motto of making the right thing the easy thing to do, and ending up promoting the quality of life, healthy development, healthy behaviors across the whole lifespan. This is the U.S. goal about public health. But there are many challenges. I think we've already introduced this idea about the slowness of clinical research. Why is clinical research so slow? And I think for most people, it's because randomized controlled trials, RCTs, have been the mainstay of clinical research. But traditional RCTs are slow, they're expensive, and they rarely produce findings that are easily put into practice. And I'm sure many of you have heard this, that on average it takes about 17 years before even a small fraction of research findings lead to changes in care. Why is this so? And this is just one example of research to practice pipeline. You have priorities in government and philanthropy for research funding, but then you have this whole odyssey for almost 20 years before it comes out on the other end for practice. And this is just one example. So not only does research take a long time, but it's often not relevant to practice. And that's because the RCTs, because of the way that they're conducted in carefully selected populations under ideal conditions. And this makes it difficult then to translate for the real world when you no longer have these ideal controlled experiments. And even if you do implement a tested intervention into everyday clinical practice, there's often a drop in the impact or the effectiveness. And so how many people know Larry Green? He's a very esteemed public health researcher in the U.S., and this is one of his favorite quotes. If we want more evidence-based practice, we need more practice-based evidence, meaning look at the context of practice and how that will inform research. So just again, another concept about RCTs. And in public health, we know when everybody talks about RCTs as the gold standard, but it's often not appropriate or feasible. How many people would want to be a subject in a parachute study? You know, we know that parachutes are helpful as you jump out of a plane, but does anybody want to be the person who's in the control group? No. It's the same thing for community studies. When I work in community studies, people don't want to be the control group. They want to have access to what they think are evidence-based programs that will benefit them. So RTCs are often helpful, but we would say in public health, not essential for supporting causal inferences. And that's because they too can have threats to internal validity, and we know about the threats to external validity. So we have systematic comparisons that show over time, on average, there's often a close correlation between randomized studies and observational studies. So what happens, we talk about translation, and there are different translations. There's T1, which is from bench to bedside, and then there's T2, which is from sort of bedside to clinical practice, or T3 into community, and then T4, which is into implementation research. But instead of going from bench to places, we often go from bench to bookshelf, where nobody ever implements the very important findings. So let me just give some glossary of terms, which I'm sure many of you are familiar with. Evidence-based interventions. Interventions that have undergone sufficient scientific evaluation to be considered effective, and it's often being published in peer-reviewed journals. Dissemination, which is different from diffusion, it's that active or targeted distribution of information and intervention materials to a specific public health or clinical audience. And then we have implementation, strategies to use or adapt evidence-based interventions within specific settings to improve population health. So I know that these talks, these keynotes are being streamed, but also if people would like my slides, I will make them available. So we really do need a paradigm shift. So if we want implementation science to reach its full potential, what we have to do is change the way scientists create evidence, how they prioritize publications, how they synthesize research. All this needs to shift so that we have greater stakeholder input and improved reporting on external validity. That means making your research more relevant and more representative. This shift is going to improve the relevance of research, and it's also going to provide information that helps policymakers in decision making. So let me get down to the Riain Framework. This is a framework that's been used, as I said, in both planning and evaluation of clinical and community-based programs. It provides a tool for talking about elements that are critical to both practice and research. There's nothing magical about Riain, but it is a way of ensuring that we have excellent research and research that can translate into practice. So let me talk a little bit about the original Riain. Russ first published an article in 1999, and you'll see the citation here. And here he's laid out Riain as a framework that would help evaluate both prevention and health behavior programs. And here's a piece of trivia that you might not know. Riain sounds so good in public health, but at first he wanted it to be ARIM, which really doesn't have the same cachet. So let me go through the different pieces, the different dimensions, and sort of focus in on the question that's being asked. Reach. It's how do I reach the targeted population? Effectiveness. How do I know that my intervention is effective? Adoption. How do I develop organizational support to deliver my intervention? Implementation. How do I ensure that the intervention is delivered properly? And maintenance. How do I incorporate the intervention so it's delivered over the long term and sustained? So what's unique about this framework? One, it was built and developed to facilitate the translation of research to practice. It acknowledges the importance of both internal and external validity, but it really emphasizes the importance of representation and relevance. It looks at both individual factors as well as organizational or setting factors. It looks at public health with combined elements. It's not just the effectiveness of an intervention, but it's how many people are reached. And it also now has a whole set of resource materials for both researchers and community leaders. And I'm not sure how many people have looked at the website, but it's recently been updated, and it has all kinds of information that I would recommend. So here's just an idea of the different domains. If we think about two different interventions, if you look at the solid lines, we'll have an intervention that has high efficacy and maybe high cost. But look, it has lower reach and much lower adoption, implementation, and maintenance. On the other hand, you may have a lower efficacy intervention. It may be lower cost, but it's going to reach more people. It's more likely for organizations to adopt it. It's more likely to be implemented because it's less complicated and maintained over time. So we have to look at all of these dimensions when we're really thinking about what's the true public health impact of our interventions. What I'm going to do is give the definition, and then I'm going to talk about some of my own studies. And this is a national study of chronic disease self-management program. So definition of reach, the number, the percent of the target organization, and the representativeness of those who participate or are exposed to an intervention. So what do we find in this study? We're talking about CDSMP, again, chronic disease self-management programs. In practice, there have been more than 300,000 older adults who have been enrolled in these programs. And that sounds like a huge number compared to research studies that often have 100 or 200, but it's really only a small percent of the 35 million Americans who are older and who have chronic diseases. So it may sound like a lot, but it's still a small fraction. And in research, even fewer. So we had workshops, and we figured out that almost 2,000 people, when we recruited, were interested and expressed interest in these workshops, but fewer sign up for the study, and they complete an initial survey, and even fewer actually enroll in the study. So it's still a lot, it's 1,000, but it's almost half of the people who start off showing that they're interested. So you can see about 60% enroll from the original who has showed interest, but then when you look to see who's in the study still at 12 months, it's about 57%, and then when you look at who has 12-month data, it's even less. But the good news about these kinds of more translational research studies is that they are much more representative of minorities than the traditional RCTs. But like many programs, there are still predominantly females who show. And in this particular study, about 80% of the women show. So what we need to do as researchers is learn how we can get more men into health promotion studies. Let me go to the second element, which is effectiveness. And that's looking at changes in outcomes, impact on quality of life. But it's not just the positive things, it's also looking at whether or not there were any adverse outcomes. So what did we find? And I'll have some specific slides. That CDS&P was effective in meeting the triple aims. Are you familiar with the triple aims? This is better health, better care, and better value or better cost ratios. And the good news is no adverse effects and many positive ones. So let me look at better outcomes. And you can see here we looked at self-assessed health, we looked at depression, quality of life, unhealthy physical days, and unhealthy mental days. And so the most improvement was around depression, but also improvement in the reduction in the number of unhealthy physical days. And this was controlling for gender, age, race, ethnicity, education, and number of chronic conditions. And then when it comes to better care, we looked at medication adherence, and that's where we got the most improvement. But these interventions are also designed to improve communication with your clinician, and we saw significant improvements here. And then for lower healthcare cost, we saw dramatic drops over 12 months in the percentage of people visiting emergency rooms, as well as the number of ER visits. We had a drop in hospitalization over the first 6 months, but then it stabilized, and you can see. So let me go to adoption. Adoption is the number, the percent, the representation of settings and educators who participate. So what did we find? We did this study by sampling all organizations that had a chronic disease self-management license. And then we conducted an initial screening survey, and about 70% of people responded. But of all the people who responded to the survey, only 10% met our eligibility criteria, and that was that they had delivered enough of the programs that we felt confident, and that they had already adhered to the fidelity of these programs. And then we selected the eligible ones in random order. And the good news is only 2 of the people who met the criteria refused because they said it's just too much work, or we don't have the personnel to do this. Let me talk about implementation. Again, the definition, the extent to which a program or a policy is delivered consistently, and the time and the cost of delivering these programs. So what did we find? We started off with organizations that already showed high fidelity to being able to deliver the programs. So we do think that we had high fidelity because CDS&P is a highly scripted program. There are fidelity manuals, there are fidelity checks all through the program. We had a really high, and almost 80% of people who stayed from the first session to the last session. And then we estimated the program cost, and we calculated the cost savings. And we actually have a tool that enables us to do this. So what did we find in terms of the estimated cost savings that were related to those findings I showed about reductions in ER visits and short-term reductions in hospitalizations? We found that there was about a $700 per person savings in healthcare utilization. But you have to deduct this from an average cost of about $350 per person to participate in the program. And so you end up with a per person net savings. But then what you can do is you can take this, about $350 through 63, and figure out if you could reach even 5% of Americans who have one or more chronic conditions, you'd be able to save billions. This is one of the reasons that the Chronic Disease Self-Management Program has taken off, because it's been proven to be effective and also very cost efficient. Let me talk about maintenance, and maintenance can be at either the individual or at the setting level, but it's sustained changes in outcomes and impact on quality of life, and again, not having adverse outcomes. So what did we find? Most of the gains did hold over the 12 months, not the hospitalization, but most of the others gains we had over 12 months. The effect sizes, they were still modest, but the improvements for better health, for better healthcare outcomes, were typically stronger at 12 months than at 6 months. And again, the hospitalization rates were one of the short-lived aspects. So we did see outcomes sustained over 12 months by and large. What about at the systems level? And this is the extent of discontinuation, modification, or sustainability of an intervention. And what did we find? That there's been dramatic growth in the offering of CDS-MP classes. When we started, there were about 100,000 people who had enrolled, and as I say, now we have over 300,000. And this is because I believe the classes are based on a train-the-trainer model, and there's also infrastructure that's self-perpetuating. And the research that we have done, particularly around cost, has helped provide a justification for continuing national support through aging services networks. So why Riain? Riain has been developed and nurtured by several federal agencies and private foundations. Back when Russ first started in 1999, right around 2000, the National Institutes of Health, the major funder of health research in the U.S., looked at the applicability of Riain in the Behavior Change Consortium. And this was the mission statement, and this was a unique opportunity to have Riain investigators work hand in hand with researchers that were trying to look at behavioral change interventions. And so what they talked about is having a framework that would help you evaluate interventions in its broadest sense, to be able to look at criteria for success, to gauge the evidence for prevention effectiveness, and also to translate for translatability. And then because people were in the middle of the beginning of their interventions, it was used to aid in the design of the interventions that would look at fidelity, reach, adoption, sustainability, to look at these domains as people were actually conducting their interventions. And then emphasizing that, yes, these were all randomized clinical control trials, but also that it was important to look at external validity. So they came up with this concept of pre-aim. What do you do at the beginning? And so there's this classic article that talks about beginning with the application in mind. How do you use Riain to design, to plan behavioral change interventions that will enhance dissemination? And this is just an example of looking at one of the dimensions, looking at reach. So again, the questions that we asked all the interventionists to say is, what % of that target population are you going to come into contact with? So in my case, how many older people with chronic conditions are you going to bring into your programs? Will you reach those that are most needy? And we know programmatically that we often reach the easiest to reach. And will your research participation reflect that population you're targeting? And so not only did we talk to investigators about the questions they should ask, but we gave them strategies on how they could enhance future translation and dissemination. So formative evaluations with who's using and who's not using the programs. Small-scale recruitment studies, what's going to work best to get the most diverse populations into your studies? How can you identify and reduce participation barriers and being able to use multiple channels of recruitment? Let me go to another program, and this was funded through the Robert Wood Johnson Foundation, a large philanthropy, and it was really a translational research study. And the questions that we asked to begin with, do evidence-based successes from RCTs, are they going to translate into community settings? Are they going to be of the same magnitude? Because remember, often the magnitude is less when you get into real-world studies. Are the populations served going to be more representative? How might you need to adapt your interventions? And can these programs be sustained over time? So again, we worked with the Riain investigators, and you can see these are many of the dimensions of Riain. So what were the two programs? One, Active Choices, telephone-based physical activity counseling, and the other was Active Living Every Day, a small group lifestyle physical activity program where you learned about setting goals and dealing with barriers. So this is an example of how you need to balance fidelity, adaptation, sustainability. We had a process by which people could consider adaptations. So the cardinal rule of evidence-based interventions is you don't want to change the essential criteria of what makes it evidence-based, but you can look at things which are really in the delivery of a program which may not be essential to what makes the program evidence-based. So we began by working with the program developers and having them identify essential core elements. Why do they think their program was effective? And then we examined the impact of proposed adaptations. And I think often what happens is people say, oh, it's just too hard to, stick to an evidence-based program. People aren't going to like it. But we really said, try, see what works. And then if there are things that you want to change, actually test what impact those adaptations would have. So Active Living Every Day started off with the 6 months, and the program developers said, to obtain behavioral change on physical activity, I need a 6-month program. The people who were delivering the program said 6 months is way too long. So what we did is we actually tested out a reduced program that was only 3 months. And what did we find? You could reduce the program. You could still use the core behavioral change principles of priority setting and looking at barriers and motivating people, but you wouldn't impact the results. So what we now have is Active Living Every Day is one of the Administration for Community Living's evidence-based programs. It wouldn't have been at 6 months, but it could be at 3 months. So let me look at sustainability, and again looking at Active for Life. Often people think sustainability is something you look at after you've finished your intervention. Absolutely not. You need to plan for sustainability for the very beginning. So again, we worked with Russ Glasgow and our colleagues to develop a 3-stage sustainability action plan that began the moment the programs were implemented. And that was to identify organizational strengths. What is it about your organization that's going to enable you to implement that program, but also sustain it over the long run? And again, we identified program adaptations that would make sustainability easier, and we had people create a long-term action plan. And you can read more about this in this Translational Behavioral Medicine journal article. So what did we find were, there were 12 different programs, and almost all of them sustained over time. But what were the factors that we found that were effective and associated with sustainability? One, programs are more likely to sustain if you can demonstrate program effectiveness, if you can align the priorities of the program, and here the programs were getting people more physically active with the organizational mission, and to integrate programs within existing structures. So what were some successful strategies? People identified program champions. They worked on enhancing community ownership of the programs. There were adaptations to reduce program delivery cost, and there was also a plan for long-term funding after the initial funding ended. Why is Riain taking off in the U.S.? I think it's because there's been a lot of national support. The Centers for Disease Control, they have adopted Riain, and particularly in the Healthy Aging Research Network, and this is one of their applications for healthy caregiving. Also, the Administration for Community Living, the major funding organization for older adult services, they have a variety of interventions and grantees, and all of the grantees were required to consider Riain in planning and implementation. And this is one example of a Riain monograph. What we did is we actually looked at some of the grantees funded through the Administration for Community Living, and we asked them, you're required to use Riain. How is it that you're doing this? So you can see planning, implementation, and also maintenance. But perceived ease of use. You can see that most people said that the elements were easy, but that it required specialized expertise because the grantees were not researchers, they were people in the community. And let me get to some lessons learned. When you're promoting and sustaining evidence-based programs, it's going to take technical assistance. You can't just expect community grantees to immediately understand and implement all the Riain elements. You have to work through community channels to broaden the reach. You need to have a training infrastructure. It's so important to integrate both clinical and community perspectives and maybe focus less on effectiveness, but on the return on investment and also upfront expectations for building sustainability. So what are some new areas that in the evolution? One, it used to be mostly on things like obesity or chronic disease, but now Riain is looking at health policies, multi-level community interventions, the built environment, patient-centered research, always with the concept of focusing on the context. So this is just an example of how it might be applied to the built environment, some questions. A personalized medicine has become so popular, and here are the questions that are relevant. Again, you can see all 5 dimensions. What are some emerging issues that are related to more sophisticated uses? So one, collecting data on the representation and the reasons why people participate. It's using mixed methods to more fully understand implementation. It's looking at the relationships among the different Riain dimensions, and it's more transparent reporting. Look at the adaptations. Be really clear about how the intervention has stayed the same or has changed. So there are a lot of mechanisms of promoting D&I research, the NIH roadmap, there are program announcements, there are community groups of people interested in research to reality, and there are even training institutes. So here are some characteristics of what influences evidence-based interventions, the intervention itself, research designs, or the context. here are just the concepts of theories and frameworks and models. But I think what's important is to look at the flexibility of the constructs, to look at whether the model looks at dissemination and or implementation, and whether or not the intended impact is at the system, the community, the organization, or the individual level. So Riain is one of about 86 unique models. This is really important. It's a website where you can select different models, you can look at adaptations, integrations, and so important for researchers, what are the constructs that you might measure? And this is an example of measurement, constructs, acceptability. So this is the last slide. I've already gotten the hand. So what is it that I think will advance Riain and other D&I models? One, to recognize that each of the Riain dimensions, reach, effectiveness, adoption, implementation, and maintenance, provides a target for intervention. So you can improve each of these. That it's often important to engage in qualitative research to understand the implementation processes. And this is a plug. We're going to have a workshop. One of the workshops is going to be on process evaluation. And it's so important to get away from standard RCTs to look at pragmatic trials so that you will have relevant evidence-based interventions. And then the interventions can look at effectiveness, but maybe you might want to simultaneously look at different implementation designs. What's going to work to make that intervention work for the most numbers of people? And then what I'd like to end up with is what is so important, and that is to establish a relationship between researchers and stakeholders to really do what we would call participatory research. This will make your research so much more relevant, and hopefully not 17 years from research to practice. Thank you so much.